about the recent study. We have actually, it's a pilot study that we have, these are preliminary results that we have gathered from a small study we did on the upright MRI Center in London together with Professor Francis Smith and two doctoral medical students, Gustav and Tove. And we all know the theme for today is whiplash, and I thought, as I'm the first speaker, I just wanted us to remind ourselves about the classification that is still in use, even though in Sweden sometimes don't want to use the fourth one, but it's I think it's very much recognized that we have this classification of whiplash injuries, and that one may ask why we have a classification, and I actually would like to have some interaction with you. Why do we have a classification of whiplash injuries? Why do we try to have it? Why was it today?
Because the insurance companies want to make a prognosis for if you are going to have big problems or not.
Yes, it's a prognostic indicator. Yes, that's one of the reasons. I would think that at least there is one more indication. Why should we try to classify injuries like this? I think most of you are treating these kind of injuries, as I understand. Does it have any impact on the treatment if it's classified as 0, 1, 2, or musculoskeletal thing, or if it's a neurological impact, or you nod? What kind of impact does it have?
Yeah, the amount of treatment, the input or the start of the treatment would be different if it's a 0 or a 1, 2, 3, or 4, of course.
Yeah, it should be at least.
Yes.
And I think we may consider that there is quite a difference between if we do have nerve involvement or instability, then we need to be more careful with our treatments. And definitely the insurance companies will judge differently if we find nerve involvement or instability signs. And so this is just a typical case. I think we've all seen this. This is a man I met. He was a runner, and this is not actually his train. There's no photo of the train accident, but he was the train driver, and the brakes didn't work, so he had to follow the train all the way into the bump, or I don't know what it's called, but so it was coming full speed ahead and bumped into the end point, and he was thrown. He entered the emergency, and I read his journal entries, and there is noted that he has a small bump in his forehead, and otherwise he was, as I think most would say, thoroughly examined. There were no neurological signs, and this is a statement that was followed by no details. This is a typical entry. He had tender neck muscles, and he got this diagnosed, stretched muscle, and he got some pain. The patient's experience was that, as he told it to me later on, the doctor pinched his neck and gave him. So he was not that happy. And he was told, as I think most patients are told, that if just in case you get any problems in the future, you should go to your family doctor. Yes. And he did have some problems. Actually, he had problems 20 plus years since that day, and At that time, he was referred to me, and in the waiting room he made this drawing, this comfort drawing. And he had visited hundreds of clinicians, and still the diagnosis was muscle inflammation. But during those 20 plus years, he had also done a number of radiological exams and other exams, all that were non-indicative of any serious injury or nerve injury or dislocation. He had not been able to continue his work, and insurance companies did not consider him. But as I looked at this drawing, I don't know if you use the drawing, but what is your feeling? Is that the man with nociceptive problems, psychiatric problems, or possibly neurological problems? What thoughts go through your mind? You know, these are actually the only three. Oh, I need that. Okay. Wait. No.
I think one of the comments on the list is very important to add to the picture, that the pain drawing, and that is worse after each physio session.
Yes.
You didn't comment that, but I think it's very
Yes.
important to understand the drawing.
Well, the drawing is made in Sweden. I'm sorry about that. I haven't translated. It's his own drawing. It's his own words. And I don't know if you agree with me, but there are only three diagnoses actually, as physicians at least we use. When I teach KI, I say that you only need to know three diagnoses. That's what you're done here for these 11 semesters. And the three ones are: is it a nociceptive, a local problem that the patient has, whether it's a eye problem or gastric or whatever, or is it psychiatric, or is it a neuropathic, or possibly a combination, of course. But the drawing itself, does any one of you get a feeling? Does he have a lot of nociceptive problems all over the body like this? Well, I think you might consider that this is not so, statistically not so possible that he should have all these different nociceptive problems, local problems. Rather, you can get a feeling that there's a pattern of, that might remind us of nerves. Though he didn't have that diagnosis. Well, anyway, the physical exam of this man revealed all these findings. And he had, for example, hyperreflexia. And his sensibility was deranged. He had allodynia. He had a sensation of when you touched, he got pain. You even could blow and he experienced pain in some of the areas. Well, and one of the signs was also when he tried to lift his arm, he couldn't lift the arm. But as you did a slight traction of the head, he could lift the arm. So he had also, of course, the diagnosis of impingement. But the impingement was not a nociceptive character. And as we consider these three diagnostic possibilities, the drawing itself, the physical exam findings, and the standard MRI, I think some of you may have looked at a number of MRIs, and I know Francis has thousands and thousands, and he will tell us much more about this, but you can all see that there is some things going on here, though the radiologists in this case did not consider that that would be a problem. It's not a neurological impingement, and that might be because there is fluid passing through the whole spine. Well, anyway, this was just one patient, and this was one of the many patients I've seen that has triggered my interest for what about the correlation between radiological findings and clinical findings of patients. And as we did some background search before this study at Medsarena, we found an article from 2001 where the author also notes that examination in supine position are highly problematic. And I skip here a few sentences, but the suggestion is examination in the upright position appears to be mandatory, and specifically in some cases. And these are the cases that are outlined in this paper. And I put in, I emphasize when there are movement and exercise dependent symptoms. Like in this patient's example, for example, he had less problem when he was laying flat on his bed, or when he didn't move his arm or his head for that case. He had movement and exercise dependent symptoms, this train driver. Or, as also is suggested by this paper, when there's a discrepancy between the clinical symptoms and the static radiological findings. As my assessment of this patient was that he had clear and neuropathic pain, based on the drawing and the physical assessment. So, we also have from this article an example of it's Orsak and et al. Who has done a sample of how the MRI drawing or the MRI picture may change from a standard to an upright position, where there is increased or diminished space in the spinal canal in the upright position. We will see a number of these cases, I think, in a few moments. Otherwise, there are very few articles on the correlation or the use of upright MRI or positional MRI in the upper spine, the cervical spine. I found one article from 2008 with two cases where they happened to find that there was an instability by doing positional MRIs. And there's a review on the diagnosis and treatment of atlantoaxial dislocations from Zhang et al. From 2014, where they note that patients may have atlantoaxial dislocation that we need to look for by measuring the distance between the ends and the front part of the like this. And if you add to the search clinical examination and positional magnetic resonance and the cervical spine. You actually find all of these in a PubMed search. So what I want to say is there is very little literature and very little knowledge about what is the correlation between clinical findings, upright or positional MRIs, and the cervical spine. There is much more, not much more, but there is more on the lower spine. But that's not the theme for today. And so, in summary, we wanted to investigate this correlation between the upright MRI and the physical examination findings, specifically concerning nerve involvement and or instability. And for this purpose, we used the method of having 2 medical students and 31 consecutive patients from Innova Med, which is a company in Norway that helps patients with whiplash injuries come to Med-Serena Clinic and get an upright MRI. We had these inclusion-exclusion criteria, and there were 2 of them who were excluded because they were actually they couldn't fulfill the whole examination protocol because they were in too bad shape. And we used a modified examination schedule. I think many of you may have seen this. American Spine Association examination schedule, which is to be used in a Swedish way, according to our whiplash dictates from 2004, I think it was, 2005, the Whiplash Commission. We have a Swedish version of this. And so these are the physical examination procedures that we did. And in more detail, we made a dichotomous judgment of several things, the range of motion, the nerve stretch tests, the sensory tests to touch and pain. For touch we used just the fingers, and for pain we used pinwheels. And these are the indicator areas we tried on sensibility. The reflexes and the motor strength indicator muscles that we used. And we also made palpation and neck compression. We did not use the Sperling's test. The reason is that many of these patients were obviously positive to Sperling's as a foramen compression test just by their own range of motion inhibition. And so we didn't want to make them feel worse than they were before. So we used just a straight neck compression. And the neck traction test, very, very gentle, very gentle. And there were some patients that were worsened in their experience than by just this test. And the protocol that we then used was the cutoff line was in case of nerve involvement that they should have at least 2 physical assessment signs positive for the same nerve and the same side to get a yes. Otherwise it would be a no nerve involvement. And for instability we used this as they had to have 3 or more, or 2. This was 2 or more, and that 3 or more to be judged as unstable in the cervical spine. And the patient characteristics, yes. The median age was 50. We had a number of 29 patients who fulfilled all the criteria and went through the whole protocols. And there was quite an even number of men and women. And you see they had problems for a long time, 13 years. So these are not first day patients, but they are they have had problems for a long time. And the VAS scale, these were questions about what was the beginning, how did they all begin, and traffic accidents and other accidents was about as common. So there could be horses slipping on the ice in the winter, or many other different things. They could have hit their head in a something going like this, and so it's whiplash and other whiplash. If it's very strict definition, should have been a lash, but I would say that not every patient could actually say that they had been in a whiplash, but they had been in some kind of head or neck injury situation. And that makes the cohort a little bit broader maybe than what we would say whiplash. And so results. We in this preliminary presentation we have made stratified the nerve segments to 3 segments, and this is the inter-examiner reliability for assessment of nerve involvement and instability. You can find the percentage of agreement was quite good, but as you take into account the chance of having correct, you have to use a statistical analysis called kappa. And kappa is, for those who may not be familiar, kappa is a value which can take on any value from +1 to -1, and it's 0 would be the same as 2 apes, or by chance. It's what you would find if you didn't know anything. And +1 is that you have exact agreement. The 2 examiners, or even if you're more than, you will have exact the same assessment of everything. And this is the opposite, of course, -1. So, according to statistician Altman, the interpretation of these values would be that they were quite good, or good actually, in these levels. Fair. It goes from, the classification goes actually from 0 here to above 0. No, this is poor, fair, good, from no, and then no, I'm sorry, moderate, and good, and then excellent up here. It's about 0.8. And of course, you may note that in this segment of the spine, the assessment was only fair. And that raises a question: how come it's such a difference from being good in these and fair in this? And I will maybe come back, but or I can tell you right now, it's a matter of how many observations you actually had in this population. And we had very few observations in this population. compared to the observations in these areas. What is more interesting maybe is that the assessment for cervical instability was only moderate. Yes, please.
In your opinion, what is cervical instability? Is the inability to dynamic control the movement, or is it segmental real instability?
Very good question. Actually, the definition we made, or the judgment we used to put the diagnosis unstable, was that the patient experienced difficulties to do either of these movements. They experienced that something was wrong. They couldn't do it because they felt unstable, as I showed in another slide. But maybe the question is better. What you mean? What could cause an instability?
No, but what is an instability? Because it can depend on that many things.
Yes.
So I think I've been 41 years in the business. I think it's very, it's not easy to tell if it's an instability.
Absolutely.
It's much more easy to say it's no mobility.
Yes, yes, and you're completely right, because as I show here, it was more difficult for two examiners to decide on or agree on what is instability. And so this is just a pilot study to try to start some kind of discussion on what signs should we use to judge the instability. How can we judge that? That's exactly what we want to raise the question. Today I think instability is actually a radiological diagnosis. It is what the radiologist sees when he sees an allostasis or an obvious tear of the ligaments in the spine, or even if there's a skeletal fracture or something like that, which is very, very rare. But the ligament tear causing allostasis would be the radiological most common way to see an unstable spine. And for this cause, we need to listen to Professor Smith in a moment. He will discuss this much further. The correlation between the student's assessment of these things compared, or the correlation with the radiological findings of Professor Smith, you can see that there is it's actually a poor correlation in the upper cervical segments. It's a moderate correlation in the mid-spine, where the most of the findings were. And there's again a poor correlation in these lower segments, and also a poor correlation in the assessment of instability, just as you were supposing. And so this raises the question: did we use the correct assessment measurements to put the diagnosis instability? Probably not. But this is how we did it in this little study. And we have discussed some of these points. I have not shown you the detailed inter-examiner reliability of the different tests we did, just the global assessment of nerve involvement or not. But I can give you a detailed. Maybe I should ask you which one of the tests do you think had the highest inter-examiner reliability of those specific test that we did in the physical exam. Was it the measurement of the range of motion? Was it the neck compression, neck traction, reflexes? Was it motor strength, sensibility to touch, or sensibility to pain? Do you have any guesses on what was the most reliable test?
Neurodynamic test. The neurodynamic test?
That was your guess, yeah? That's a good guess. The nerve stretch test. It wasn't, but that's a good test. That's what is commonly suggested in the lower in the examination of the lower spine, that a positive leg or straight leg raising is the most reliable test. But is in this study this was not, and I actually can rely on another study where I have done this together with a very experienced examiner. We also did specific inter-examiner reliability testing of 63 of the most common tests we use in the upper spine. We have published this in Spine several years back, with about the same findings as these students now did. And I think this is worth a few moments, because it's actually may affect the way we think of our own findings. You know, we need to use assessment that are reliable, because if they're not reliable, in other words, if it's not sure that you and I will see the same things, then why use that kind of physical assessment? Then reliability is only one thing that needs to be, but that's a very important thing. And so if I can get you to consider, let's see how. We had reflexes, range of motion, we had nerve stretch test, sensibility, touch, pain, motor strength. Yeah, we can put them in these categories. Did I lose someone? No. Yeah, traction. Yes, traction and compression. That's right. So, which of the tests do you think we had? We have already got one guess. Which was the best and which was the worst, according to this little study, and even actually the other study I did on 100 patients, consecutive patients with neck shoulder pain. It was the same result actually as in this study. Well, you won't lose anything from guessing. Range of motion? You would put that as the best or the worst? The best. You think that's the worst?
Yeah.
And this is the best, okay? The worst? Worst. Okay. Do we have any further suggestions?
Compression.
Would be best or worst?
Best.
The best test. Yeah, this is looking very interesting. Can I get some further suggestions, even that?
Touch sensibility.
Touch would be the best or worst? The best. Does this side dare to say something?
No, I'm just wondering, the succession, were they doing these different tests with the with the examiner one after the other? I
No,
mean, what was the
no.
time
Yes.
lapse and so on? Because
Very good question.
repetitive testing would also probably
Yes,
change
yes.
the
Very, very clever comment. The question or the comment is, how was the procedure done? Well, the patient was came to the the radiological clinic, and they were first in the camera. They did the MRI scanning first. Then they went to an examination room, and one of the med students made the examination, signed all the papers, and went out. And then the second examiner came in and did the same examination without no time into it. Everything was straight in one. So that could affect the results, but as I did in my PhD work, I did a similar thing where we were two examiners. We actually had two patients come at the time, and then we switched rooms, and we randomized who started in what room. So and the results from that study is very much the same as this. And you have now noted that it's a great. Well, we actually the reflexes. I don't remember the exact value from this study, but I remember it from my own PhD studies, and we managed with something incredibly difficult, namely to get worse than 2 apes. The reflex hitting minus 0.16. So that's quite an astonishing. But that tells us something about how difficult it might be to assess reflexes. And of course, there are reflex signs that we should be very much aware of, like, for example, the man I told you about in the beginning, hyperreflexes. But otherwise, it's a very difficult test to do. And having worked in a hospital for many years, when I see this journal entry, neurological no neurological signs, I always wonder, what is that? And I have, this is not research, but I have a feeling that is reflex testing.
Might it be a problem that you don't define what you don't have a line between neurological findings and symptoms, because they are twisting together, and you are so different when you make the examination and an old neurologist in the old school does.
Yeah, might be. I'm just I just want to make the point that don't rely on only reflex hitting. It might be very difficult to judge. No, and actually the only test of these that reached 0.6 was this.
I can't see which one.
Sensibility to pain with the spurs. Pinwheels, yes. And the closest was to touch. So this is maybe a little hint that you might take notice of.
Sorry, on your list there, you didn't put up palpation. So
That's right, palpation also. That's right, we use palpation. And most of these other tests actually hit somewhere here. Palpation, range of motion, nerve streak, motor test. They come in here moderate. But this is about there. So, with that said, it might be worthwhile to learn to do a thorough neurological examination with the at least the sensibility, and to use the bimanual testing material method, not just ask the patient, can you feel this? Because of course they can, if they don't call in a they won't have a stroke, and then they will always feel, but you have to get the patient to answer, is it the same? The correlation between the assessments or the upright and the physical was moderate in these segments and lower in those other segments. Yes.
Sorry, one question. The examiners, what was the experience of the examiners? Would you expect the results to change with experience, or do you have any other studies that can give us some numbers on that?
Yes, very good. Thank you for that question.
Repeat.
Yes, I'll repeat. What was the experience of these examiners? And would it change if they had had more experience? That's what you're actually asking. And these were med students, semester 7 at Karolinska Institute. So they were unexperienced, very much. And I taught them before they traveled to London. This is the protocol, do this, and they had to train on each other. And I even invited, I think we had 2 real patients where they practiced. So they were very much unexperienced. But again, as I also mentioned, I've done this similar study with an experienced companion before, and we didn't get the same results. Actually, in that previous study, we made these 100 patients we examined. We checked for the first, and second, and the third part of these 100 patients, and we increased our inter-examiner reliability. Yes, we did, with time. And that's quite normal, I would say. But these tests are, I would say, it's one of the conclusions you can actually draw, that it's a very simple test. It's so simple that you can reach a good reliability from just starting without more than 2 patients' experience. So it's worthwhile doing it. As I also mentioned, we had quite few observations in these upper and lower segments, and that makes the results less reliable per se. And instability testing was poor, and we have discussed that as you very much noted. Well, I don't know. What would you say? How should we judge instability from a clinical exam? Do you have any tests that we could use in a future study? How would you, in a physical exam, say that the patient is unstable or unstable or not? I'm interested, because that's a key question of today's lecture. You have an idea?
No, I'm just thinking that is it even logical to expect that you can put a number on it? Because you would expect mobility, right? And instability would indicate that it's more than just normal mobility. So
Yes.
then you would have need a value that you need to exceed. And we don't have that number as far as I know for normal mobility.
No, we still rely on the radiological exam.
Yeah, and it's not reliable enough.
Well, we will hear from Francis what his opinion is on the reliability of the radiological.
I mean today.
Today, yes. Gunilla.
I believe that many physiotherapists are very good at making a segmental
Analysis.
palpation and
Yes.
trying the movability. And that, in my experience, is best test to find the level of instability from the patient's reaction. If there is after pain and very, very much not pain directly, but a feeling of very bad sense.
That comes back to what we actually try to use, the patient's experience of instability. How they feel that when I do this, my head is going to fall off. That's a very subjective feeling, but it would be very interesting to just ask the patients. Actually, now I don't have these data, but many of these patients said it's like my head is falling off. It feels like I have to hold it when I travel with the bus or the car, not to fall off. So this needs further studies to see if we can find some kind of reliable test. Another interesting result in our study was that the examiners found quite much more frequent nerve involvement than did Francis on his MRI. And the opposite was in the case of instability. And how could that be? Why would the physical examination reveal more nerve involvement than what is seen on the MRI? You have any ideas on that? Because that's also a key question I think we should all be aware of. This is not just this study.
Was this examination upright MRI?
This was upright MRI. They did an upright MRI just the minutes before they went to this physical examination. Yes?
Because MRI catches things around the cervical spine.
Yes.
The neurodynamic test can perhaps indicate some entrapment or dysfunction along the peripheral nerve.
Exactly. The MRIs still are there to show us mechanical nerve involvement. Okay? But nerve involvement may come from at least two other sources, which are temperature. We all have put our hand in a cold or hot space. That is not seen on an MRI. And the maybe most common thing is the chemical influence involvement, the cytokines in the discs and the inflammatory cytokines that are produced in an injured area might cause nerve involvement that is not visible on any MRIs of today. And so it's not an unreasonable finding in our study that we found much more nerve involvement. Also, of course, you can, if we have an impingement, a mechanical impingement of in the lateral or close to the medulla, you may see that this should affect the C3 nerve or something, but it might also affect the C4, C5, C6 due to its compromising the nerve stem. Well, I should add that this cohort is a very specific. You cannot generalize these findings to the whole cohort of that patient, because these are patients that have traveled far and long and to a great cost to get these examinations. And so we cannot say that this goes for all patients having been in a whiplash injury. And of course we need much more studies on this subject of how can we correlate clinical findings and radiological findings. Yes. And in conclusion, the nerve involvement findings correlate to a higher degree than the assessment of instability. And we really need your help and everyone who is interested in research to make up protocols that can be used in the physical exam that can indicate or make reasonable that we should do a more thorough radiological exam, maybe in preparation for a surgical intervention. Thank you. These are team members and those who helped us do the study.
But,
Questions? Yes.
you can go the other way back and have a patient you know has instability, and then you do a lot of tests on that person, and then you see which
Yes.
test is the best, because you have the answer in the patient.
Yes, that's a
Then
very
you can
good
try
idea.
another.
That's one way to do a study and to specifically find those. But we need also to have healthy controls, I think. Any other questions or comments, please? 1 minute left. Yes.
How about functional MRI scanning?
Yes. Please listen to Professor Smith now.
Okay.
It is. What's the next topic? Okay? Thank you.